Can you explain to me what PIDAC standards are?
PIDAC stands for Provincial Infectious Diseases Advisory Committee. It is a group of experts in the fields of infection control and infectious diseases, and they are the ones who vet all of the best practices. So they look at things from World Health Organization, CDC, in the States, all of those other expert groups, and they bring them to Ontario to say these are the standards that we expect to be met within Ontario.
Is it PIDAC standards that your infection control people would follow then? That would be the standard baseline training?
Yes, our housekeeping, our infection control, all follow PIDAC standards.
Okay. With respect to outbreak management clinical practice, recommendation number 1, suspect and confirmed CDI patients should never be cohorted together. Was there in this outbreak or any of the outbreaks here cohorting of suspected and confirmed CDI cases?
As we understand it, and I was not aware, this obviously had happened at one point prior to the outbreak, that this group has raised to us and said we should not be doing that. So of course that will be our follow-up.
Yeah. One instance of it? And
I don't know the numbers, but we do know they were very small numbers. So they wanted to make sure that we were all very clear that this should never happen.
And this, I'm sorry, you said prior to the outbreak?
As I understand, yes.
So this was in the time frame of a few weeks before the outbreaks were declared?
As I understand, they asked the questions about has this ever happened, and the answer they were given at some point in their interviews was yes, this has happened in the past. So it was in the past. We don't know exactly when. Clearly our staff are the ones who will live this every day, and they will identify that this has happened. We don't know dates, we don't know exact times. And the team was very clear that if it happened once, it could happen again in the future. We need to be very clear that it can't happen.
Just to be clear, why don't you want to cohort suspect and confirmed CDI patients?
I'll probably ask Joanna to answer that.
Because each of them is at a different stage in their disease, in terms of days. So you can't put a confirmed case that has had for 7 days, for example, with a suspected case, because if that suspected case turns out to be negative, you have just raised the possibility of the negative suspected case developing the disease.
And as I understand it, I'm looking at the recommendation to be communicated to all IPCs and Infection Prevention and Control Committee members. Taking a look at what the PIDAC recommendations were going back to 2004, the non-cohorting of patients who had suspected CDI was standard operating procedure.
Yes.
So why?
Clearly we had a mistake somewhere along the way. Clearly, and that's what we're learning from and saying. We have to understand that all of our placement of suspected or confirmed cases are approved through our infection control practitioners. So they make that decision, and at some time, someone slipped through the cracks, and that's what we're saying. We can't let that happen again, and we won't let it happen.
So this is like reinforcing that basic. Just in terms of the second recommendation on cohorting. If cohorting of isolated patients becomes necessary, the first choice, and so on. I take it your first option is, if at all possible, have them in private rooms, right? Don't cohort anybody together.
Yes.
But cohorting is actually a very typical practice within a lot of hospitals, including the NHS.
It can be, for sure.
Right. So, for example, when you have the number of cases you have at Greater Niagara General Hospital right now, between CDI and VRE and other things, that's a heck of a lot of isolation burden. And that occurs why? Why wouldn't you put them into individual rooms?
We don't have the number of individual rooms. It's as simple as that. So the new hospital in St. Catharines will be 80% private rooms. That will have a huge impact on our ability to find the space for individuals to appropriately place them. When we don't have that space, these are the algorithm rules that we follow. Right.
But in fact, it's not a question of room. We have hospitals that have entire wings that are shut down. Think of, there's a ward at GNGH that's been closed for years. We have at Douglas Memorial oodles of beds that have been closed, from maternity beds to inpatient beds. I would suspect the same at Port Colborne. It's not a physical plant size thing.
It is and it isn't. I mean, it's very complicated. You have to staff those beds appropriately. You can't, and I'm a nurse, so I can't work on a unit and have a patient here and a patient, 15 miles down the road in another place. We're staffing to the number of patients, and the number of patients have to be within some geographic reality for staff to be able to staff them. So what we have done in some of our areas, though, is expanded into those beds that originally were closed and expanded to increase the number of semi-private and private rooms. So we have a floor here, for example, that had a section that was closed. We reopened it, but what we've done is spread it out. It is more difficult for the staff because there's a lot more walking involved in making sure that, when they're doing their rounds, it's further to go, etc. But it's, clearly we're looking at best practice.
What would be a ballpark of your current bed utilization, percentage-wise? Are you running 95% bed utilization?
We run 100% and over.
100%. So with 100%, that doesn't really give you any leeway in the time of an outbreak unless you and I'm not criticizing, believe me, you do something ad hoc, open up some extra beds someplace or whatever.
We do on occasion do that. So we have what's called an overflow policy. So when we have more patients than we have room for or beds for, we open up different areas. So at GNG there are a number of beds on one unit, a number of beds on another unit. At Welland there are a number of beds on each of the units, plus there's another whole unit that on occasion when our situation gets bursting, we open that unit. We have to staff it, so we have to make sure that we have appropriate staff. We obviously have an availability. There's a health human resource shortage, so our challenge sometimes is we may have the beds, but we don't have the staff to staff them. Those are the questions every day that we look at. So when we normally have what we call a bed meeting, we have that every single day. That's the discussion that happens. So we have this many patients that are in emergency or this many that are coming in for surgery. These are the number of beds we need. How many patients do we have? If we have more patients than we have room for, the discussion goes around, do we have staff? Can we bring staff in for the other areas? Can we add another 2 patients to that unit, etc.? We have a whole protocol that we follow in determining when to open beds and close them, etc.
Last question, this has to do with the